And we'll end with the last talk, which will be by Dr. Thornthun Ueaphongsukkit. I'm sure I mispronounced your name, for which I apologize in advance. Dr. Thornthun is a MD and also did her training in internal medicine here at Chulalongkorn University, and is now doing her research in the context of the Thai Red Cross AIDS research family, I would call them. And you will be talking to us on metabolic issues, so the floor is yours.
So thank you very much for that introduction. I'm really honored to be here. My topic given to me is to talk about metabolic complication, but more specifically, I will talk about the training topic here, the integrase inhibitors and weight gain. So I would like to start with a case. So this is a case, a female patient aged 39 years old. She was diagnosed with HIV since 2010, and she was enrolled in a project at the HIV-NAT and was given TDF, FTC plus boosted atazanavir. And she became virally suppressed within 3 months of treatment, and after that she had an uneventful clinical course. After 3 years, however, she was enrolled into another project, and her ART switched to elvitegravir, cobicistat, and TAF, and FTC. And here is what happened. So at the time of the switch here, she weighed around 68 kilograms, and her BMI was around 25. And after 3 years of the switch, her weight was 77, and her BMI became 28. It was around 10 kilogram weight gain in 2 years. So I would like to ask you all for opinion. So is it because of the elvitegravir, or do you think that is from something else? So let's do the vote. Okay, so the answer is B and C. So maybe it's from TAF, and maybe it's from her lifestyle. So actually, I don't really have the correct answer. I think it's just an opinion, and everything could be multifactorial here. Okay, so let's continue with the case here. Again, after 3 years of elvitegravir, she was rolled over to another ART, and this time she was switched to big TAF or bictegravir, FTC and TAF, and this happened again. So her weight at the start of big TAF was 77, and the latest weight last month was 89.5, and her BMI changed from 28 to 33. So what do you think this time? Is it because of bictegravir, or is it something else? So let's do the vote. Okay, so again, everyone seems to think the majority is they think it's from TAF, and the next one is from her lifestyle, and lots of people say not sure. So let's see. So what do we know about integrase and weight gain, integrase inhibitor and weight gain at the moment? I will review the evidence here, and first of all, I will talk about the evidences in ART-naive group, and there are many trials being conducted. The first one, the data from ACTG A5257 were presented in CROI in 2017. It was a randomized trial conducted in the US and Puerto Rico in ART-naive HIV-infected individuals. They were randomized to one of 3 regimens of TDF, FTC plus boosted atazanavir or boosted darunavir or raltegravir. And so The outcome were defined severe weight gain if the percent weight increase was more than 10%, and severe BMI gain was an upward increase in BMI category. And the total participants in the trial are around 1,800, and mostly are male. And the result at 96 weeks showed that the odds of severe weight gain and severe BMI gain were significantly higher in Latiglravir arm comparing to the PI arms. The next one is the advanced trial. So the advanced trial, the data were presented in last year conferences, and the advanced trial is a 96-week randomized trial in South Africa, enrolled around 1,000 HIV-naive individuals to receive one of the three regimens, TAF FTC plus dolutegravir, or TDF FTC plus dolutegravir, or TDF FTC and efavirenz, which is the standard of care in South Africa. So the results show that there is increase in weight across three study arms, higher with the DTG than efavirenz, which was statistically significant. And the treatment emergent overweight and obesity were both higher with DTG than with efavirenz. Noted that for all three parameters, the changes were greater in the TAF-containing arm compared to the TDF-containing arm. And also from the data presented in the conferences, women had greater weight gain compared to men, and the changes in weight seem to continue after week 48 compared to in men, which became plateau around 48 weeks, and after that, they didn't gain more weight. The next study, the NAMSOL, is a 96-week randomized trial recruiting around 600 treatment-naive patients in Cameroon. So they were randomized to receive either TDF lamivudine plus dolutegravir or TDF lamivudine plus 400 milligram of efavirenz. So the result at week 48, there were increasing in weight across both study arms, and statistically significant higher with DTG arm than efavirenz arm. Changes in BMI and treatment emergent clinical obesity were both higher with DTG than with efavirenz. The next one is a pool analysis of weight gain in 8 randomized controlled trial conducted by Sachs and colleagues in last year with more than 500 ARV-naive participants combined. So at weeks 96, participants taking INSTIs experienced the most weight gain with 3.24 kilogram compared to NNRTI at 1.9 and PI at 1.7. These are statistically significant, and also participants taking bictegravir or dolutegravir demonstrated similar weight gain, but both greater than those taking cobicistat boosted alvitegravir. The next two stories are from Berge and colleagues reported last year. The first one is a single cohort study exploring the weight gain by ART class among around 1,100 ART-naive patients and predominantly male. The weight gain was highest among those studying dolutegravir. At 18 months, the dose on dolutegravir gained around 6 kilograms compared to 2.6 for NNRTI and 4.1 for PI. And the next one is the NA cohort, sorry. So the NA cohort is a large multi-center cohort collecting data from treatment-naive individuals starting ART regimen containing INSTI in RTI or PI. So they explore the weight gain by ART class within 5 years of ART initiation and weight gain by each INSTI DARC within 2 years of ART initiation. So the total participant is around 24,000 patients were included, and around 4,700 of them were on INSTI-containing regimen. Weight gain was highest among those starting INSTIs and statistically significant when compared to NRTI at 5 years. And among INSTI, those starting latiglravir and dolutegravir gaining significantly more weight than those starting alvitegravir. So we move on to another group of patients, the ART experienced or switching group. The evidence for this group of patients mainly consisted of retrospective cohorts conducting in the US and Europe, and the magnitude of weight gain seemed to be more modest than in ART-naive studies, and they also show conflicting results. The first report is a retrospective cohort study from Norwood and colleagues published in 2017. So they assayed weight change over 18 months in patients who switched from efavirenz TDF FTC to an INSTI-containing regimen or a PI-containing regimen, and compared to those who continued the same regimen. They also did a subgroup analysis comparing among INSTI type. So the patients who switched to an INSTI-containing regimen gained an average of 2.9 kilogram at 18 months compared to 0.9 kilogram among those continue on the same regimen. And the differences was statistically significant. And among the subtype of INSTI, those switched to dolutegravir, abacavir, lamivudine gained the most weight at around 5.3 kilogram, but the differences among INSTI subtype were not statistically significant. The next one is the NEAT study. Is a randomized trial comparing data between dolutegravir-based and boosted PI-based regimen at week 48 with a total of around 500 high CVD risk participants. So at week 48, the median weight gain was higher in DTG arm comparing to boosted PI arm, but please note that this is less than 1 kilogram change here. Another one is a study from McComsey and colleagues presented at CROI last year. So it's a retrospective observational study describing the characteristics of treatment-experienced adults who had more than 3% annual weight gain. Among around 3,500 patients, only 30% had annual weight gain more than 3%. In bivariate analysis, the percentage of patients with the outcome was significantly higher among patients treated with INSTI comparing to those not treated with integrase inhibitor. However, this was not significantly in multivariate analysis. Another study presented at CROI last year is from Lake and colleagues using data from 2 ACTG switching trials with around 700 participants. In this one, the differences in annual weight gain pre and post switch were significant in those who switched from both PI and NNRTI to dolutegravir-based regimen, and those who switched from NNRTI to abitigrapir-based regimen. And among the subtype of integrase inhibitor, annual weight gain appears greater with dolutegravir than abitigrapir or lartigravir, but with, again, the modest number around 1 kilogram. Another evidence is from HOP study. The HIV outpatient study is a cohort study in the US using medical record data from 9 HIV clinics. The mean change in weight on integrase inhibitor-based switch regimen was greater than that on non-integrase inhibitor-based switch regimen, with a small attitude of around 0.9 kilogram difference. Here, the result from a women's study from Women's Interagency HIV study by Kirschberger and colleagues, again presented at CROI last year and also published in October last year. They used data from a large longitudinal study of women living with HIV on ART. By selecting those who switched to or add an integrase inhibitor to ART compared to women on non-integrase inhibitor ART, the total of around 1,200 participants, and with around 234 on integrase inhibitor. So compared to the non-integrase inhibitor, the group that used INSTI experienced greater increases of 2.1 kilogram in body weight at 2 years, and there were no differences observed among the subtype of integrase inhibitor. The next study from Burns and colleagues, this one is conducted in the UK, and this one showed no change in rate of weight gain post-switch to integrase inhibitor regimen. And the next one, the last study I would like to mention here is presented in Switzerland last November in the European conference. This is the other one that showed no association between integrase inhibitor and weight gain. It's called HIV cohort in the Netherlands, which contained both HIV positive and HIV negative participants. The mean weight gain and clinically relevant weight gain defined as more than 5% and 10% changes after switch to integrase inhibitor in HIV positive patients were compared to those in non-switching HIV positive and also to HIV negative participants. So the total number of participants is around 600 HIV positive. The switch group around 120 and were matched with 271 non-switching participants and around 500 HIV negative participants. So they used time-dependent propensity score match. And the results show that there were no significant differences in yearly mean change in body weight within and between the groups before and after the switch. And however, a more than 5% increase in body weight occurred significantly more frequent in HIV positive participants after in-state switch compared to non-switching and HIV negative control. So from the evidence of I've already mentioned the causes of weight gain seen in integrase inhibitor use could be multifactorial. It could be from the return to health effect. This could contribute to the more robust weight gains seen in ART-naive individuals. And the late GI side effect of integrase inhibitor could also lead to good appetite and finally lead to weight gain. And also with current diet and lifestyle, even general population also tend to gain more weight and become overweight and obese. And being female and of black race are already associated with weight gain in people living with HIV after ART initiation. So it could be multifactorial of these factors combined. And the study already mentioned before from McComsey and colleagues, they show that the weight gain associated with neuropsychiatric disorder in multivariate analysis. The use of psychiatric medication could have been the explanation in that case, because those have been known to increase weight in the general population as well. Another factor here I would like to mention is the NRTI backbone. This could be one of the causes of the weight gain. Here from the advanced trial, show that TAF gained more weight and became more overweight and obese compared to those used TDF. And from the pool analysis by SAC also showed that TAF caused significantly more weight gain compared to other NRTIs. So NRTI backbone could also be the cause here. How about the possible mechanism? So there seems to be an association between integrase inhibitor and weight gain, but we don't really know the mechanism behind that. From in vitro study, dolutegravir was found to inhibit binding of alpha melanocyte stimulating hormone on melanocortin 4 receptor. This is believed to produce hyperphagia and increase in food intake, and it could be the mechanism behind weight gain found in those on dolutegravir. However, more researchers are needed to confirm in vivo effect and to find other mechanisms for the explanation of other integrase inhibitor. So is it a bad sign to gain this weight? What are the weight that has been gained? So in advanced trial, they did the DEXA scanning to show changes in body composition after ART initiation. So in male participants, changes in trunk and limb fat and lean mass were both higher in the dolutegravir arms, but you can see here that most of the weight gain is the yellow color here, which is fat. So most of the weight gain is the fat gain. In women, increases in trunk and limb fat and lean mass were higher in both the TG arms here than the efavirenz arm. But again, that most of the weight gain is fat and even more higher than in male participants at around more than 70% here are fat. Looking at the outcomes of the weight gain, so in advanced trial, they checked the metabolic syndrome prevalence, and at baseline, the prevalence of metabolic syndrome was similar across all arms. But at week 96, there were significantly more participants reached the diagnosed criteria of in TAF arm when compared to the standard arm. And the changes in lipid parameter were also statistically significant between arms, but the magnitude of changes was very small and likely to be clinically insignificant. In the other study that I've already mentioned, in the women interagency HIV study, there were modest changes in lipids and glycemic control in integrase inhibitor containing arm, but the overall changes are so modest and during the short-term follow-up and were unlikely to be clinically relevant again. So in conclusion, there are more robust evidence for integrase inhibitor and weight gain in ART-naive individuals, and especially with dolutegravir, but the causes of the weight gain in such patients are more likely to be multifactorial. The mechanism behind the weight gain in integrase inhibitor use is currently unknown, and more researchers are needed in this area. And the weight gain, as far as we know, are more likely to be fat more than lean mass. The short-term data show no clinically relevant changes in lipids and glycemic control, but long-term data are not yet available. So in our context here in Thailand, so integrase inhibitor will become part of the preferred first-line ART in Thailand, likely this year. And dolutegravir is expected to be available nationwide soon. You have to keep in mind that all the studies mentioned hardly involve any Asian participants, and Asians have lower BMI threshold to the diagnosis of overweight and obesity, and more body fat at the same BMI, so compared to the Caucasians. So this could lead to different outcomes in Asian population when using integrase inhibitors. And that would be the end of my presentation. Thank you.
Thank you very much for an incredibly comprehensive overview of a very timely and complicated topic. Presentation is open for questions. So while we wait, first of all, you mentioned on your last slide that you're going to have dolutegravir in the region soon. So I was wondering, in the setting where you work, are you planning any prospective studies on this, in this area?
Yes, actually. We're planning to do more study using dolutegravir. Yeah.
Because you have the opportunity, of course, to look at it. And the other question I had is you reviewed the naive studies and the experienced switch studies, and of course it's striking that the effect is less in experience, but which tells me that part of the effect in naive is probably return to health, part of it, yes. And there's something in addition. But I was wondering, with respect to the TAF story, have you been able to tease out from the experience studies to what extent TAF was in the mix or not? Because it's probably a big mix, but I've never heard anyone from those studies talk about to what extent people in their studies use TAF or not.
So during the preparation for this presentation, I've looked through lots of evidence, but like you said, I've never came across the study that mentioned TAF and weight gain in experienced group. Yeah.
Right. No other questions? No? Okay. Well, thank you very much again.
Thank you.
And